Men referred for prostate biopsy almost always arrive anxious, because no one explained what actually happens. Today I am walking you through every single step, in order, with complete honesty about what you will feel and why. I am Dr. James Whitaker, board-certified urologist, and today I want to walk you through exactly what happens during a prostate biopsy. Every step, in the order it happens, with honest description of what you will feel and why each step is necessary. I want to do this because the men who come to my clinic most anxious about this procedure are almost always men who received a referral for biopsy with almost no explanation of what the procedure actually involves. Their anxiety is driven not by any genuine understanding of what happens, but by imagination filling the gap where information should be. Today I am filling that gap with complete, honest, clinical information. First, let me explain why a prostate biopsy is recommended, because understanding the indication helps contextualize the decision. The two most common reasons a urologist recommends a prostate biopsy are an elevated or rising PSA level, prostate-specific antigen, a protein produced by the prostate gland that can be elevated in prostate cancer, BPH, prostatitis, and other conditions, and an abnormal finding on digital rectal examination, where the examining physician detects a nodule, firmness, or asymmetry in the prostate that warrants further evaluation. A PSA elevation alone is not a diagnosis of prostate cancer. Most men with elevated PSA do not have prostate cancer. It is an indication that further evaluation is needed to determine whether cancer is present. The most commonly performed prostate biopsy technique today is transrectal ultrasound-guided biopsy, or TRUS biopsy. An increasingly used alternative is transperineal biopsy, which approaches the prostate through the skin of the perineum rather than through the rectum, and has advantages in terms of infection risk reduction that are making it more widely adopted. I will describe the transrectal approach in detail, as it remains the most common technique, and note where the transperineal approach differs. Before the procedure, your urologist will review your PSA history, any prior biopsy results, and your current medications. If you are taking blood-thinning medications, aspirin, clopidogrel, warfarin, apixaban, rivaroxaban, you will typically be asked to stop these several days before the procedure, with specific instructions depending on the medication and the reason you are taking it. Never stop any prescription medication without explicit guidance from both your prescribing physician and your urologist. Antibiotic prophylaxis, a short course of antibiotics taken before and after the procedure, is standard to reduce infection risk, although the specific regimen has been updated in recent years based on antibiotic resistance patterns. If you have specific allergies to antibiotics, this must be communicated clearly before the procedure. On the day of the procedure, you will typically be asked to perform an enema beforehand to clear the rectum, reducing bacterial contamination during transrectal biopsy. Arrive early. Wear comfortable clothing. You will be asked to sign an informed consent form. Please read it carefully and ask your urologist to answer any questions before signing. You will then be positioned on your side on the examination table in a modified left lateral decubitus position, lying on your left side with your knees drawn up toward your chest. Some urologists perform biopsies with the patient in lithotomy position, similar to a gynecological examination, but lateral decubitus is most common for TRUS biopsy. The ultrasound probe, which is approximately the size and shape of a large thumb, will be lubricated and gently inserted into the rectum. This produces a feeling of pressure and fullness that most men describe as uncomfortable but not painful. The probe contains both an ultrasound transducer for real-time imaging and a guide channel for the biopsy needle. Your urologist will use the real-time ultrasound images to evaluate the size and appearance of the prostate, identify any suspicious areas, and plan the biopsy distribution. The next step is local anesthetic injection, periprostatic nerve block. A thin needle is passed through the guide channel of the ultrasound probe and positioned at the junction between the prostate and the seminal vesicles on each side, where the nerves that supply the prostate run in a bundle. Local anesthetic, typically lidocaine, is injected into the tissue at this location on both sides. Most men describe this injection as a brief, sharp sensation or sting, lasting 2 to 3 seconds per side. After the injection, 2 to 5 minutes are allowed for the anesthetic to take effect. With adequate nerve block, The subsequent biopsy needle passes are felt as pressure and movement, but are not significantly painful in most men. Please subscribe to this channel right now. I am Dr. James Whitaker, and this is exactly the level of clinical detail that I believe every man who has been referred for a prostate biopsy deserves to have before the day of the procedure. Hit subscribe, hit like, and drop a comment right now. Have you been referred for a prostate biopsy and have questions? Tell me what you want to know. I read every comment and I will answer. The biopsy itself is performed using a spring-loaded biopsy gun with a hollow core needle. You will hear a distinct clicking sound with each core. The spring mechanism fires the needle rapidly through the prostate tissue, acquiring a cylindrical tissue sample approximately 1 to 2 millimeters in diameter and 12 to 15 millimeters in length. Standard systematic biopsy protocols acquire 12 cores from a defined distribution across the prostate, typically bilateral samples from the base, mid-gland, and apex, plus any additional targeted samples from areas that appeared suspicious on ultrasound or on prior MRI imaging. Most men describe each core acquisition as feeling like a brief, sharp snap or sting, different from the continuous pressure of the ultrasound probe, and not significantly painful with adequate nerve block. The entire biopsy needle insertion and core acquisition sequence for all 12 cores typically takes 15 to 20 minutes from the time the probe is inserted. You will be asked to lie still during this period and to let your urologist know immediately if you feel anything that seems significantly more uncomfortable than what was described above. After the cores are acquired, the biopsy probe is removed. You will be asked to remain lying down for several minutes. Your urologist will give you specific instructions about the antibiotics to continue afterward, warning signs of complications, and activity restrictions. What to expect in the days following the procedure. Blood in the urine, hematuria, is essentially universal after prostate biopsy and typically persists for 1 to 5 days, occasionally up to 2 weeks. This is expected and does not indicate a complication. Blood in the semen, hematospermia, is also essentially universal after prostate biopsy and may persist for several weeks, occasionally up to 2 to 3 months. This is because the seminal vesicles adjacent to the prostate are in the biopsy field, and any microbleeding within prostatic and seminal vesicle tissue is expressed during ejaculation. Blood in the stool is less common and usually minor and brief. Some men experience mild perineal discomfort or pressure for several days. The complication that you should watch for and treat as a medical emergency is fever above 101 degrees Fahrenheit, accompanied by chills and feeling systemically unwell, signs of sepsis from post-biopsy infection. This complication occurs in approximately 1 to 3% of transrectal biopsies despite antibiotic prophylaxis, and in a smaller proportion of transperineal biopsies. If you develop fever and chills in the days following your biopsy, go to the emergency room immediately. Post-biopsy sepsis can progress rapidly and requires intravenous antibiotic treatment. The biopsy cores are sent to a pathologist who examines them under the microscope. Results are typically available within 7 to 10 business days. If cancer is detected, the pathologist assigns a Gleason grade and grade group, the internationally standardized system for describing prostate cancer aggressiveness. If the biopsy is negative, no cancer detected, your urologist will discuss follow-up PSA monitoring and, in some cases, repeat biopsy timing if risk factors suggest that a negative biopsy may be a false negative. I am Dr. James Whitaker. You are now fully informed about what to expect. Subscribe for weekly medical content. I will see you in the next video.